Alright, welcome back. We can really consider this part 2 in our lesson and talking about vasopressors as we have this collection of lessons talking about the different ICU drips. In this lesson, I wanted to cover several different areas of information that's good to know, especially when you are managing your patients who are on vasopressors. But before we begin this lesson, if this is your first time to this channel and you'd be interested in watching more in-depth critical care educational content, then we do invite you to subscribe to our channel below. Make sure you guys hit that bell icon though, that way you'll be notified as soon as the new lessons become available to you. We truly value the subscriptions, the likes, and the comments that you guys leave. It really goes a long way to help support this channel, and for that I do want to thank you guys. Alright, and for those of you who don't know me, my name is Eddie Watson, and this is ICU Advantage. Alright, so let's go ahead and get into the information here. Like I said, this is going to be good to know info. So now in the last lesson, I really talked about what vasopressors are, gave you guys a good understanding of that, the different receptor sites that the different vasopressor medications are working on, as well as covered each of the different vasopressors, the effects they have on different receptor sites, the different concentrations and dosing ranges, and how quick we would expect to see the effects and titrate these medications. So all that information is very important, and if you haven't watched that, I'm going to link to it up above. But specifically when it comes to vasopressors, these are one of the most common medications that we're going to be dealing with within the ICU. And so it's really important that you guys have a good understanding of how to manage your patients who are on pressors. And because that's so important, there were some extra things that I wanted to talk about specifically when it comes to managing these patients. And so the first of these topics that I want to talk about is titrating pressors. And so essentially this is the act of dialing in the proper dose of pressor, either up or down, looking to produce the optimal effect for your patient. And how to do this is really one of the most commonly asked questions by new nurses within the ICU, and it's also one of the more difficult things to understand being a new nurse in the ICU. For those who are experienced and have new nurses that they're precepting, it can also be very difficult to try and explain this because after working in the ICU for a while and titrating these medications enough times, you almost sort of get a sense for it, which makes it difficult to try to explain how to do this. So that's going to be the purpose of this here. So really, in order to better understand how to titrate medications, you must know the ranges for each medication. So obviously this is going to be dependent on your particular hospital's policy. And the reason for really needing to know these ranges is because let's say you have at your hospital levo is in a range of 1 to 50 for the dose. And let's say your patient is on a dose of 5. If you were to increase that dose by just 1, you're going to have a significant effect for your patient. This is going to be a 20% increase in the dose that they're getting. Whereas if your patient is on a dose of, let's say, 20, going up by 1 is going to have much less of an effect. It's only going to be a 5% increase. So you've got to know what these ranges are, as well as what the current dose for what your patient is getting falls within this range. And the goal that you're going to want to be doing is based on whatever your patient's MAP goal is. You need to determine how much or how little you need to either increase or decrease this rate to get you to that goal MAP. And so where this sense comes from that people who've been doing this for a while really is rooted in knowing how far off your MAP is from your MAP goal, and then basing how much of a change you need to make in your pressor dose in order to bring it back in line with that goal. So again, as an example, if your levo is running at a lower dose, but your patient's MAP is quite a ways off from your MAP goal, it's going to take a smaller adjustment in the dose that you're giving your patient to bring that pressure back up to where it needs to be. So kind of pay attention to how your patients are responding to changes that you make, and look and see how much is your MAP different from where it's supposed to be, and how big or small is the dose that you're currently giving your patient in relation to the total range of dose that you can give. And this is where you're going to have to make your adjustments up or down, either in small or large doses, depending on how much they're already getting, and also depending on how far off their current pressure is from the goal that you want it to be. So it definitely does take some practice. It takes some intuition to sort of understand what's happening and the process that goes into this. And hopefully this bit of information will give you that little bit of knowledge you need to give you that intuition. Now, the other important thing to know when we talk about titrating meds is that you're not going to see the effects immediately. And so if you remember back in the previous lesson, there's a time for onset and a frequency in which we're going to titrate these medications. Now, when you make changes for your patient, this is going to be tough, but you need to give it some time to see what the effects of that change are going to be. Like I said, this can be really difficult if you walk in and your patient is hypotensive, especially if they're profoundly hypotensive. But even if you were to crank that levo up to the max, you're still not going to see the effect of that immediately. And so what happens with newer RNs is they tend to over-titrate. So they either go up too much or they go up too quick because they're not seeing a response. And this leads to them overshooting and having to reverse course, and they end up making many more unnecessary titrations. Again, this is going to happen to you, especially being new, but hopefully with that intuition of how much you need to be making the change and a little bit of faith in knowing that you just have to give it a little bit of time for that medication to hit your patient and to start working. And hopefully that will help to reduce the number of titrations that you have to make. Some patients are going to be very labile, their pressure is going to be changing a lot, and no matter how good you are at this, you're going to be in there constantly titrating these pressors. But you really want to try to avoid overshooting or undershooting and really reduce the number of titrations that you have to make. And I'll kind of hit back on this point here again. It's really important to know that this is very much dependent on your hospital's policy. So this goes as far as the ranges that you can go with your medication. Oftentimes the orders will tell you how often to titrate these medications and by how much. And in fact, the Joint Commission lately has been really strict in adhering to the expectation that we're titrating these medications in accordance with the way that they are ordered. And you might even find yourself in a facility where nurses don't have the ability to make titrations, and any changes that need to be made to the rate need to be ordered by a physician. So it's important that you know your hospital's policy on managing these medications, but if you do have that ability to titrate these medications, hopefully some of this information will go a long way in helping you guys out. Now, another thing that I want to talk about here is your line setup. And let me tell you, there's nothing worse than having a tangled mess of lines all wide together with no labels, and your patient starts crashing. It's an awful situation to find yourself in, and so I'm going to give you some tips here, one that will make your life easier, but also make the lives of your coworkers easier as well. The first and probably most important thing I can put on here is label your lines. And when you do this, you want to be labeling your lines at the pump as well as at the end where they connect to the patient. You want to be able to know quickly looking at your pump which medication it is, as well as if you need to access that medication at the patient, you need to know which line is which. Colors work great if you guys have color tape available, but if you don't, just some sort of tape with writing saying what the medication is going to be absolutely important. The last thing you want to be doing when your patient is crashing is tracing your lines back, trying to figure out what line is what. Now, another thing within the lines that I want to talk about is the Y site. So that's that site right at the end of the line, right where it attaches to the patient, where you can attach additional lines to it. And I don't want to tell you guys not to use these. Absolutely, if you're in a pinch, if you need to get something going quickly, absolutely use the Y site. But once you find yourself where you have the time, where you really start adding multiple drips all together, it's going to be imperative that you switch to some sort of manifold to better control the mixing of these medications. Essentially, a manifold is something that has a couple different connectors on here to where you can plug in different medications, and they all mix in the same area before going out to the patient. These are great if your facility has them, specifically if you have access to them within the ICU, but if you don't, then you can also chain stopcocks together in order to make a manifold. And so here, essentially, you have your stopcocks, and you just hook them together just like this. And this way you can have all your medications going right to this spot here. And the reason that you want to do this is because let's say you have 3 or 4 different pressors going and each one is wide into the next one. You have some lines that are a mix of 2 pressors, some lines that are a mix of 3 pressors, some lines that are a mix of 4 pressors. And let's hope you don't have to make a change to that last one that's wide in there, because by the time it works its way all the way down through all of those Ys and eventually gets to your patient, it's going to be quite a while. So by having a manifold or creating a manifold out of stopcocks right at the point where the medications are coming together is right as it's going into the line that you're giving it to your patient. Therefore, you can make changes and expect to see those changes quickly. The other thing that kind of goes along with these manifolds is going to be our flush line. And our flush line is essentially some sort of fluid that's running either into the manifold or into the end of the stopcock, typically some sort of TKO line. So really, unless you're running high doses or multiple pressors, you're really going to want some TKO line to flush in behind your pressor. To really understand this, let's think about if you were to start your patient on levo and you're just starting them at, let's say, 2 or even 5, and you hook it up directly to the hub. It could take potentially 5 to 10 minutes for that medication to work its way through the lumen of the line and eventually get to your patient. But if we have a TKO flush line that's infusing at a slightly faster rate, when you add that medication to it, it's going to help to carry that along and get it to your patient quicker, therefore seeing quicker the effects of changes that you make. This also will go a long way if you need to disconnect the medication and, God forbid, your line does not want to pull back so you can't get that medication out of the line. Important thing to know here, if your patient has a swan, do not use the infusion line on the swan. That line is far too long. It's going to take way too long for that medication to get to your patient. And once again, if you have to stop the medication, that's a whole lot of medication you have to get back out of there. Now, sort of along the lines with talking about our lines here, it's important that you never flush the line with pressors. If you flush these lines, you're going to give them a big dose of pressor, which is going to have severe consequences for your patient. Along the lines of this, you also never bolus your patient with pressors. You'll see anesthesia will do this often, but this is something that you guys should never be doing. This can cause major problems and it can even kill your patient. So a couple key points with the lines here. Most important thing, make use of what you have at that moment, but as soon as you have the time, make sure you organize your lines the proper way. So now next, let's talk about central lines. And so when it comes to pressors and central lines, best practice is for pressors to be infusing through a central line. Now, many hospitals actually have policies that require you to do this, but also remember, if your patient is crashing and all you have is a peripheral line, use that, get the medication to your patient, but then make it a high priority to get the central line. Now, anytime we place a central line in a patient, we do have to verify that it's good to use. And this even goes for when we have a central line that's placed emergently. And for this, the best practice is to get an x-ray. You're going to want to get an x-ray to confirm that it's in the vessel. And a little trick for you guys is if they've just placed an IJ or a subclavian, you don't want to see that line traveling down on the right side of the film, essentially the patient's left side. This is going to be an indication that this is in the arterial system. Another little tip for you guys is if they get a central line and you're not sure if it's in a vein or an artery, hook up a transducer and see what you get on the monitor. You're going to know immediately whether that line's in an artery or a vein, because you're either going to see an arterial tracing or a CVP tracing. You sometimes can use the color of the blood that you see on the central line to tell you where it's at, but this is more so going to be to tell you probably that you're in an artery, but you can't necessarily bank on this to tell you that you're in a vein, because sometimes crashing sick patients can have arterial blood that's just as dark as normal venous blood, and you just can't rely on seeing dark blood to tell you that you're in a vein. So now let's talk about arterial lines. So if you find yourself in a situation where you don't have an A line and you're having to titrate pressors, you want to make sure that you guys are cycling that blood pressure cuff frequently. And this is usually going to be every 5 minutes or less. But if you do have a patient who's on pressors, especially if you're titrating them, best practice is to have an arterial line. The A line is going to give you the most accurate reading immediately to changes. As an aside, it's important to know that the blood pressure cuff that your patient has that's going to the monitor is not actually the true blood pressure of your patient. I know that sounds crazy to hear, it halfway sounds crazy to say, but without getting too technical on how those blood pressure cuffs work, essentially there's an algorithm that's taking place based off of the measurements that the cuff has gotten, which is going to give an approximation, usually pretty accurate, of what the patient's blood pressure is. These blood pressure cuffs on the machines don't work the same way as if you were to go and get a manual blood pressure and listen with your stethoscope for the crock cough sounds. That would be a true and accurate representation of the patient's blood pressure. They work in a completely different way. Usually it's going to be pretty accurate, but if you're comparing that to a direct measurement of a catheter within an arterial vessel, you absolutely want to rely on the A line, assuming that the reading is correct. So with that said, you absolutely have to make sure the numbers are true. So this is where you want to be doing your square wave test. You want to make sure that your line is not overly dampened or that it's whipped. Both of those are going to give you false readings. You also want to check and make sure that the transducer is in the proper place. Is it lined up with phlebostatic axis? If it's too high, this is going to give you a falsely low blood pressure. If the transducer is too low, it's going to give you a falsely high blood pressure. All of these things could lead you to misrepresent your patient's blood pressure and ultimately not give them the proper dose of pressor that they need to optimize their blood pressure. Other things to take into consideration is, do they have some sort of anatomical issue that could give a false reading? Do they have some sort of aneurysm or dissection? Do they have some sort of unilateral stenosis? All of these things, if you're on that affected side with a radial A line, could really impact the reading that you're getting. So, absolutely important that you need to make sure those numbers are true and correct, because that's what you're going to be using to base your information off of. If you have any question about the legitimacy of that line, or you're definitely not getting accurate blood pressure representation on that A line, then you're going to need to move to a manual cuff until you can get another one. Alright, so the last thing that I want to talk about here is something that we call Trendelenburg position. And essentially, Trendelenburg position is where you have your patient lying with their head of the bed lower than their body. This used to be very common practice to help to raise the patient's blood pressure, especially to their head, especially if you found them in acute state of profound hypotension. Important thing to know with this is old practice and do not use it. Essentially what this does is it falsely raises the blood pressure in the patient's upper body. And what this is going to do is this is going to signal those baroreceptors in the body, and this is going to prevent the patient's own body from releasing their own catecholamines, which can come back and haunt you later. So if your patient suddenly becomes profoundly hypotensive, lie them flat, but do not put them in Trendelenburg, and get those pressors going. Alright, so not a ton of information covered in this lesson, but hopefully it was some good information for you guys. Like we talked about with the titrating of pressors, it's a very difficult thing to wrap your head around when you first start, but hopefully some of the information and the tips I've given you will give you some of that intuition that you need. Line setup is incredibly important. There's a couple different things we talked about there that are going to be very important, both for your own personal management of your patient, as well as directly impacting the effect that you're going to see on your patient. We talked about central lines and A lines. They're both best practices that we should be doing. And finally, we talked about Trendelenburg, an old practice with old nurses. It's something you guys should not be doing. Hopefully you guys found this information useful here. I hope this gives you some information to be able to take out into your practice and provide great care for your patients. And so with that said, I do want to thank you guys so much for watching. Like I said, I hope you found this lesson to be useful. If you did, go below, leave us a like, and leave us a comment. They really go a long way to help support this channel. In future lessons, I'm going to be continuing this series covering different ICU drip medications. and we're going to cover quite a few of them throughout the course of this series. In the meantime, while you're waiting for the next lesson, feel free to head on over and check out the last series of lessons that I did in which we talked about the endocrine system and covered those different disorders that you're commonly going to see in your patient. As always, thank you guys so much for watching, and you have a great day.